Hello, everybody. So good morning for those of you who are on the West Coast and those of us approaching noon in Middle America, and good afternoon to everybody on the East Coast. We're really excited today to welcome all of you to our Colorectal Cancer 101 session. We wanted to let you know that we will begin our webinar in just another 1 or 2 minutes as we wait for everyone to log in. We're very excited today that we have actually over 100 people registered specifically for this specific webinar. So just give 30 seconds to people to have you go ahead and sign on. Just a quick reminder for everyone who's on the line today, there will be the chat feature, which throughout the course of the presentation, if you have specific questions, we'll entertain those questions at the end with Kevin McAbee, our patient resources manager, who will be facilitating that Q&A session at the close of today's webinar. So let's go ahead and get started. So today we're actually featuring Dr. Dennis Ahnen, who is one of the Fight Colorectal Cancer Medical Advisory Board members. And Dennis has been a team member with me here in Colorado for over the last 5 to 10 years, working in colorectal cancer prevention and survivorship issues. And so very excited to have Dr. Ahnen joining the team and joining to present today for our webinar series. So for those of you, I'm Andy Dwyer from Fight Colorectal Cancer Unit, working in conjunction with University of Colorado Cancer Center and the School of Public Health. I wanted to just say a quick note and shout out to Michael Sola, Danielle Burgess and team, as well as Kebby for all of their support today with webinars. So follow us at hashtag CRC for webinar, along with Twitter for some external comments, discussion that we have going. And again, just a reminder to type on the right side of your screen any specific questions that you might have. And after the webinar, we will be sending out a link with materials and survey for you to fill out. So it's really helpful for us to get some feedback about how today went and any other questions that you might have. Next slide. So we actually wanted to make a special announcement today that our RATS program, which is a Research Advocating Training Support program that was founded by our founder, Nancy Roach, has really taken great strides in really becoming a mainstay and part of CRC's programming. And we opened up an application process for those of you who saw where we received many applications, and we've come to a process to accept new people into our RATS program, where we're really thinking about the ability of research advocates to effectively inform and participate in the research process with training, support, in-person meetings, as well as continued education. And this webinar series is actually brought to you from the RATS program. It's our first webinar series in our education campaign and curriculum. So a special shout out to all of our RATs who are joining in today, and then also a note for those of you who might be interested in our RATs program, we will be opening up an application process again probably in the next 6 months or probably definitely within the next year, so keep a lookout for that. But we're very, very excited to move forward and to expand this program that Nancy and team at Fight CRC definitely implemented, and we're ready to really expand and move that forward. So we're very excited. Our next in-person research and RATS Academy will be actually in Colorado on November 5th and 6th. So a special thanks to the CU team and even Dennis Ahnen in our planning of that agenda. Next slide. And just again, a reminder that Fight CRC has a plethora of resources and information available for cancer survivors, specifically our webinar series, which you're all joining today, as well as our updated Guide in the Fight. So you'll notice that red stamp of updated, the update that we actually have on our website. For those of you who have the hard copy version, definitely peruse our website and see what we've added. I know there's some specific modules about updated treatments, as well as some more information about genetic and family history. So join in our Guide in the Fight updates and check out what we have new. We're also very excited that we've also launched in the last couple of months a podcast series known as Tabooty, where we actually go through and examine some really interesting discussion points around some topics that might not necessarily be mainstream, but are definitely salient and very applicable to the Fight Colorectal Cancer and the colorectal cancer survivorship community. So check us out. We have a number of resources. Next slide. And just a quick note out, of course, is that Fight CRC provides all of the information as education, a supplement to help through the treatment as well as survivorship for families, for survivors, as well as even the medical support team. But just a reminder that we are in no way a replacement for direct medical care, and if there's ever an emergent situation, to please call 911 or visit your nearest emergency room. Next slide. So with that, as I noted, Dr. Dennis Ahnen is joining in our discussion today, who's an active clinical investigator who's worked for a number of years at the VA hospital and led a number of clinical and research initiatives in his time there, but is actually the co-director now at the University of Colorado Hereditary Cancer Clinic and directors of the genetics clinic at the gastroenterology of the Rockies. So he definitely has a long-standing history in prevention, treatment, as well as helping really inform the research agenda for over 30 years. So at a time that he's retired as a staff physician, although at the VA, he definitely maintains an appointment here at the University of School of Medicine and at the GIA of the Rockies team. But I can actually just tell you that Dr. Ahnen is a huge champion within the community as well as in the country around colorectal cancer treatment, prevention, and all things to really help improve the lives of cancer survivors. So with that, I'm very excited to turn it over to Dr. Dennis Ahnen for today's featured presentation. Dr. Ahnen?
Thanks, Andy. That was way too kind. I just, at the bottom of that previous slide, this slide, I just wanted to start off by giving a couple disclosures. I'm on the scientific advisory board for two companies that are relevant to colon cancer prevention, Exact Sciences and Cancer Prevention Pharmaceuticals. I'll probably mention actually a little bit about the products, both of those companies, but I'll try to give you a heads up at the time just so that you know. So I've been asked to talk about colorectal cancer 101, the basics of colon cancer to this group.
Dr. Ahnen?
Yes.
Sorry to interrupt. Can you share your screen? I don't think that it's showing up.
How would I do that?
Up at the top, screen sharing. Show my PowerPoint application. My apologies.
How's that?
We are not seeing. All right, and then you can, there you go, perfect. Thank you.
Now we're okay?
We're great. Sorry to interrupt.
Okay. Let me just make sure that, wow. Let me just clean up my screen here for a minute. All right, are we okay here? So this is, so it's appropriate that we start by talking about colorectal cancer, sort of in general. So what I've tried to do is to provide some data about the basics of colorectal cancer. And these are, okay, these are the topics I'd like to talk about. First, the very basic, what is colorectal cancer? What is it clinically? What is it biologically and molecularly? And how does that impact how we take care of patients and prevent and treat colorectal cancer? I'd like to talk about who's at risk for colorectal cancer and what the magnitude of the risk is, how can colon cancer be prevented, and finish up with staging and treatment of colorectal cancer. What we're going to talk about today are some of the basic fundamental concepts that I think are important to understand and to serve you well as you take on tasks of research advocacy in the future. So first of all, what is colorectal cancer? The colon is an organ that takes fluid intestinal contents from the small bowel and removes water along the course of the colon and converts about 2 liters of liquid stool to about 200 cc's of formed stool that allow you to pass that at your leisure, if you will. There are a number of segments of the colon. The most proximal portion where the small bowel enters is called the cecum. The ascending colon is shown here, the transverse colon, the descending colon, the sigmoid colon because it takes this S-shaped curve, and then the rectum. The appendix is not usually considered part of the formal colon, so cancers of the appendix are not typically classified as colorectal cancer, and cancers at the very end, at the anal canal, are usually squamous cell cancers that are much like the skin and are not included. So otherwise, cancers of all these segments of the colon are included in the term colorectal cancer or large bowel cancer. So from an endoscopist, this is the way colon cancer looks. The ability to look inside the colon with an endoscope, either a sigmoidoscope or colonoscope, has been enormously helpful in our understanding of this process of colonic carcinogenesis. And this picture shows the appearance of a colon cancer, this large lesion that's growing from this flat mucosa, very frequently ulcerated in the center because the cancer's outgrown its blood supply. But these cancers arise from precursor lesions, from polyps of the colon that look like this. And those polyps can grow and look like this. They may look a bit like a mushroom on a pedicle, and they can grow to very large sizes before they can progress to cancer, or smaller polyps can progress to colorectal cancer. This process is called the Adenoma carcinoma sequence. And this is a depiction of the adenoma carcinoma sequence, progression from normal epithelium to abnormal molecular epithelium, biologically and molecularly abnormal, but histologically under the microscope may look still normal, to small adenomas, to larger adenomas, ultimately to colon cancer that's localized and then subsequently invasive into adjacent organs. This process is called the adenoma carcinoma sequence. For a long, long time, we thought this was the only sequence that led to colon cancer. I'll show you some recent data that suggests there are other molecular processes that can lead to cancer, but this is still the dominant form of the development of colon cancer. And it's important to note that it takes a long time. On average, it takes between 10 and 15 years to progress through this process from normal epithelium to colorectal cancer. I told you that there were several molecular pathways to colon cancer. The chromosomal instability pathway shown up here is the common one, the one that we first understood, is mediated by mutational events, abnormalities in DNA, some of which lead to a growth advantage to the cell in which the mutation occurs. That cell grows into a clone of cells that have a growth advantage. Subsequent mutations within that clone of cells ultimately results in the progression along this process to cancer. And these cancers are thought to account for about 70% of colon cancers are thought to arise through this pathway. The second pathway, the microsatellite instability pathway, only accounts for 5% of colon cancer, but this is a hereditary syndrome, Lynch syndrome, that I'll come back and talk to you about a bit more. But fundamentally, it's molecularly different. This is due to a defect in the ability to repair mutations that occur normally during DNA replication. If you can't repair that process, it increases the rate of mutations in tissues and leads to colon cancer more rapidly than cancer through the chromosomal instability pathway. The third pathway is the most recently recognized and may account for up to 25% of all colon cancers. And instead of progressing through an adenoma sequence, it progresses through a different histologic pathway, a serrated adenoma pathway. So hyperplastic polyps and serrated polyps are the precursors to cancer in this serrated or epigenetic pathway. And molecularly, it's different as well, because the primary driving force is not mutation, such as those that occur in the other two pathways, but methylation of genes, alterations in the regulation of genes, so-called epigenetic alterations in genes. So this pathway is histologically different, and it's also molecularly different from these other two pathways. It may well be that the approach to prevention of these three pathways is different. It may well be that the epidemiologic causes, the risk factors, as well as response to therapy may in the future be defined by which pathway these cancers are deriving from, as much as other factors as well. So who's at risk for colon cancer? Everyone is at risk. There's no group that's not at risk for colon cancer. This slide just shows the relative importance of colorectal cancer in both the number of new cases and deaths. There are about 1.6 million new cases of cancer in the United States, estimated in 2015. About 9% of those are due to colorectal cancer, 133,000 new cases of colon cancer this year. There are about 577,000 deaths from cancer in the United States this year. And again, about 9% of those are due to colorectal cancer. Colon cancer is second only to lung cancer as the most common cause of cancer death in the United States. So this is a big issue. This is a common cancer, and it is a lethal cancer if not detected early. I show this slide to make the point that these numbers, these incidence and mortality numbers that I just showed you, are not constant. There's tremendous flexibility and plasticity, if you will, in cancer incidence and mortality over time. This slide shows the cancer mortality over time in men on the left and women on the right. And what you can see are dramatic changes in cancer mortality in both groups. For example, stomach cancer was the most common cause of cancer in the 1930s and 40s. And stomach cancer has declined very rapidly in the United States, probably because of better refrigeration and elimination of Helicobacter pylori, which is a risk factor for stomach cancer. Lung cancer has increased dramatically related to smoking. In women, uterine cancer has decreased dramatically. This is primarily due to cervical cancer reduction due to Pap smears. So incident or mortality from colon cancer can change dramatically over just a few decades. So let's look what happened to colon cancer. Colon cancer in men was relatively stable until about 1980 and has been declining. But look in women. The cancer rates, the mortality from colon cancer began to decline in the 50s and steadily declined. This next slide shows that a little more cleanly. This is incidence of colon cancer in men and women, mortality from colon cancer in men and women over time. We didn't have good incidence data until the SEER registries were established in the mid-70s. If we had earlier data, I suspect that the incidence of colon cancer back in the 50s would be the same in men and women. But what we see is that something good was happening in women before it started happening in men. So mortality from colon cancer began to decrease steadily. Don't really know what this is due to. Some people think this is due to hormone replacement therapy because hormone replacement therapy has been shown to be protective. If that's the case, then I would expect that these two curves will continue to come closer together because we no longer use hormone replacement therapy nearly as much as we did in the past. So this is really the good news. Look at this dramatic decrease in both incidence and mortality of colorectal cancer over the last 30 to 40 years. A really remarkable decrease. In fact, the United States is the only country in the world where both the incidence and mortality of colon cancer is decreasing. What's shown here is the incidence of colon cancer in a variety of countries. Just look at these top three. So the United States is in red, Canada is in green, and Australia is in blue. And you can see that the incidence of colon cancer is decreasing in the United States, but in Australia and Canada, it's been relatively stable, whereas mortality has decreased in all three of these countries substantially. So the difference between what's happening in the States and what's happening in these other countries is on incidence. We think that's because of the identification of adenomas, removal of adenomas, decreasing the incidence of new colon cancers, and part of that decrease in incidence obviously results in a decrease in mortality. But it's not only screening with endoscopy that affects mortality. Mortality can be decreased by screening with other methods because endoscopy is not the most commonly used form of screening in either Canada or Australia. So you can have an effect on mortality without necessarily an effect on incidence. And it's interesting to note that the magnitude of the effect on mortality is similar in these countries. There's benefit to decreasing the incidence because identifying colon cancer early can decrease mortality, but still requires surgery that isn't necessary if you can prevent the cancer in the first place. But the good news is that the incidence and mortality of this disease is decreasing in the United States, and mortality from this disease is decreasing in many Western countries. So who's at risk with respect to identifiable risk factors? Well, there are a number of risk factors: demographic, family history, lifestyle, and dietary risk factors that have been identified for colon cancer. Some of these are quite strong, and many of them are modest in magnitude, but there are also the risk in those who don't get screened. So I think that failure to get screening should be listed as an important risk factor for colorectal cancer. But let's talk a little bit about some of these demographic, lifestyle, and dietary risk factors. And we'll start with the demographic ones: the country of origin, age, sex, and ethnicity. This is a map of the world just showing colorectal cancer mortality around the world. And you can see dramatic differences, over 10-fold differences in colorectal cancer mortality in different countries around the world. The Western world and developed countries have the highest incidence. Less developed countries have lower, and the least developed countries have a lower incidence yet, or a lower mortality yet. But the important point is big differences in colon cancer mortality. And these are all age-adjusted. It has nothing to do with average longevity. So real differences. This suggests the possibility that there are factors that are responsible for this high rate in some countries and low rate in the other countries. This slide shows similar results, but not only for mortality, but colorectal cancer incidence, as well as mortality in men on the left and women on the right, ranked in different countries. There are 3 points to make. One is that there's still this very big magnitude of difference in incidence of colon cancer, as well as mortality from colon cancer, tenfold or more across these various countries. The second is that the more developed regions, these countries in more developed areas, have higher rates of colon cancer than those in less developed regions that are shown at the bottom of this slide. And the third is that in all of these countries, every one of them actually, the incidence and mortality is higher in men than it is in women. The magnitude of that difference can vary, and the magnitude is greater in developed countries, but in every country, the magnitude of risk is higher in men and women as an absolute risk at one point in time. Not only is the risk higher in men, but the age distribution curve is shifted to the left in men. This just shows the cumulative incidence of colorectal cancer in men and in women as a function of age. And you can see this curve is shifted about 10 years to the left in men. So colon cancers occur earlier in men than they do in women. But the lifetime risk of colon cancer is the same in men and women because women live longer than men. So lifetime, the risk is about 5 to 6% of developing colon cancer in your lifetime, regardless of sex. So, so it's important to note that there is this gender difference. This gender difference has not yet been used to make any recommendations about differences in screening, but it's important to note that there is that difference. There's also a difference related to race. And this slide shows the cumulative age and incidence of colorectal cancer in white men in black, which is about the same as black women, shown here in blue. Black men, on the other hand, have a higher, their curve is shifted to the left, their incidence at any, or mortality at any age is higher than in white men, and white women have a lower rate than both white men and black women. So there are differences both by gender and by race related to colon cancer. There are some recommendations, some groups that would argue that we should modify our screening recommendations on the basis of gender and age, but that has not yet been accepted by the major guidelines organization. How about family history? This is one that we actually do change screening recommendations based upon family history. First of all, familial colon cancer is very good evidence that genetics does play a role, and familial factors do play a role in colon cancer. This pie chart just shows all of colon cancer, and that most colon cancers are sporadic. But there's a small group of colon cancers that are well-defined hereditary syndromes due to mutations in well-known specific genes, essentially proving that genetic factors can cause colon cancer. And then there's a larger group of familial colon cancers that I'll come back to in just a second. But first, let me just mention a word or two about these two most common hereditary syndromes, Lynch syndrome and familial adenomatous polyposis. Familial adenomatous polyposis was the first genetically defined colon cancer syndrome, easy to identify because it's characterized by the presence of hundreds to thousands of adenomas in the colon. What's shown here is a colonoscopic view. This is the colonoscope coming through the anal canal into the rectum and then turned around to look at the distal rectum. And you can see within this small area of the distal rectum there are scores of adenomas. In the entire colon there could be thousands of adenomas. This is a very dramatic presentation and easy to identify, and that's why clinically this syndrome called familial adenomatous polyposis was identified earlier than the others. But it's a rare syndrome. It's caused by a mutation in the APC gene. It's an autosomal dominant syndrome, which means that it only takes, if you identify someone that has this mutation, they have a 50-50 chance of their children having inherited that mutation from them. It's associated with a very high colon cancer risk, not because each of these polyps has a high risk of progressing to cancer, but because there are so many polyps that invariably one or more of them progress to colon cancer. So very high risk, early age of onset. This is an easily recognized syndrome, and there is a gene testing that's available to try to detect the mutations in the APC gene that are responsible for FAP. So screening in this setting in known families has now become genetic screening. So individuals from families known to have familial polyposis have genetic screening, usually around age 12, sometimes earlier. And then surveillance in this group of individuals that are gene carriers is annually to try to remove large polyps and then decide when surgical resection of the colon is necessary to prevent colon cancer. So this is a rare syndrome, counts for less than 1% of all colon cancers. Lynch syndrome is the most common of the colon cancer syndromes. It's also autosomal dominant, but it accounts for about 3%, 3 to 5% of all colorectal cancers. These folks have inherited a colon cancer gene. The cancers arise in adenomas, but they only develop a few adenomas, each of which has a very high risk of progressing on to colorectal cancer. The cumulative risk of colon cancer in Lynch syndrome is up to 50% or so, so enormous risk. The cancers in Lynch syndrome are characterized by early age of onset, average age around, say, 45 or so. The average age for sporadic colon cancers is about 67, so 20 years earlier than sporadic colon cancers. These tumors tend to be located in the proximal colon more commonly. About 2/3 of cancers in Lynch syndrome are located in the proximal colon, whereas about 2/3 of sporadic colon cancers are located in the descending sigmoid and rectum. So a difference in distribution, a difference in age, and those are the hallmarks, and multiplicity are the hallmarks of this syndrome. It's not just a colon cancer syndrome. Other cancers occur in Lynch syndrome, particularly endometrial and ovarian cancer, and a variety of other cancers at lower rates, but the two most common are colon and endometrial cancer. This is clearly an under-recognized syndrome. It's been estimated that less than 5 to 10% of all Lynch families are clinically identified today. So we have a lot of work to do to try to identify these individuals earlier. They're identified on the basis of family history. We now test all colon cancers for the molecular hallmarks of Lynch syndrome to try to identify families in that way. I think we're doing a better job, but we still have a fair amount of work to try to identify these Lynch families. There's very good evidence that we should do that. Screening works in this setting. Colonoscopy screening has been shown to decrease colon cancer incidence and mortality dramatically in patients with Lynch syndrome. And the recommendations are annual colonoscopy and starting at around age 25 or 10 years younger than the earliest cancer in the family. So those are two familial syndromes, two genetic syndromes that establish beyond doubt that genetic factors can predispose to colon cancer. But I'd like to talk about this much larger group of individuals. About 25% of people that have colon cancer have another close relative with colon cancer. We don't know the specific genes that are responsible for this familial clustering of cancer, but we do know that having a first-degree relative with colon cancer increases your risk of developing colon cancer. So individuals with colon cancer are at increased risk for developing new lesions over time themselves, and screening recommendations for those individuals are well established. But having a first-degree relative with colon cancer also increases lifetime risk of developing colon cancer. Overall, as I mentioned before, the lifetime risk of colon cancer is about 5%. But if you have a first-degree relative with colon cancer at any age, that increases this risk 2 to 3-fold. If you have a first-degree relative at a younger age, say under the age of 50, or more than a single first-degree relative, say 2 first-degree relatives, it increases that risk 3 to 4-fold. If you have more than 2 first-degree relatives with colon cancer, it increases that risk 8 to 9-fold, almost to 50% level, almost to the level of colon cancer risk that occurs in documented Lynch syndrome family members. So family history is a very important risk factor, and we use it to stratify colon cancer screening recommendations, as I'll show you in a minute. The intensity of screening increases as you go along this continuum of the number of first-degree relatives with colon cancer and the age of those first-degree relatives. I'll say a bit more about that when we come to the screening section. Not only does a family history increase the overall colon cancer risk, but it again shifts the age distribution curve about 10 to 15 years to the left. This is an old study now, but it was a huge study that looked at the incidence of colorectal cancer in individuals that have no family history of colon cancer, this curve on the right, and compared that to individuals with a family history of colon cancer, either in a first or second-degree relative, showing, again, about a 10-year shift in the curve. We recommend screening in average risk population beginning around age 50. The risk in these family members of families that have colon cancer in a close relative, that risk is comparable to the average risk at about age 40. And that's why we begin screening at age 40 in individuals that have a family history in general. And we'll come back to this in the screening section. But let's talk about these other risk factors, the lifestyle and dietary risk factors. There's very good evidence, quite consistent evidence, that in populations, obesity and low physical activity are risk factors. Modest risk factors may be affecting between the highest and lowest quartiles in these groups, affecting maybe 20 to 30% increase in risk in the most obese and least physically active individuals. Smoking and alcohol are risk factors for colon cancer, as they are for several other cancers. Diets high in red meat or processed meat and low in fiber-containing foods, particularly low in fruits and vegetables, are risk factors for colorectal cancer as well. Again, all of these lifestyle and dietary risk factors are modest, 20 to 30% risk at the extremes of intake of these diets, for example. There are also some well-known protective factors. As I mentioned before, getting screened is a protective factor. And I want to say a word about aspirin. And I think there is a role for aspirin chemoprevention of colorectal cancer in selected groups. And I'll try to tell you why. Aspirin appears to affect almost every step in this adenoma carcinoma sequence. We know from population studies that populations that take aspirin regularly, usually for other reasons, for cardiovascular reasons or for arthritis, have a decreased adenoma incidence over time when you look at these populations. So, and those are observational studies. We have clinical trials showing that people have had one adenoma removed and placed on aspirin compared to placebo have about a 20% decreased risk of developing any new adenoma, and about a 30% decreased risk in developing an advanced adenoma, a large or histologically advanced adenoma. We also know from both observational studies in populations and randomized controlled trials that were done for heart disease that populations that were randomized to aspirin had a decreased incidence and mortality of colorectal cancer, again in the 30 to 40% range. And we even know that certain subsets of folks with established colon cancer have an improved survival if they take aspirin. And this is particularly cancers that are mutant in a gene called the PI3 kinase gene. And it appears to be specific to that group and not beneficial in other groups. And even in Lynch syndrome, this highly genetic syndrome, there's evidence that population in a randomized control trial that randomizing individuals who are Lynch mutation carriers to aspirin resulted in a decrease in colon cancer incidence by about 50%. But it took a long time. It took over 5 years to begin to see this difference. So it appears that aspirin has the ability to affect the adenoma carcinoma sequence at multiple levels, perhaps at every level along the way. So why don't we use it in everyone? Well, the reason is it's a balance, right? The benefit is relatively small. Lifetime colorectal cancer risk is only about 5%. The estimates from the data that I showed you would be that perhaps that could be decreased to around 3%. So a relatively small benefit overall. And even a smaller benefit in colorectal cancer mortality from around 2.5 to 1.6% on the estimate. We don't know for sure whether surveillance and removal of polyps by itself might not result in this, whether aspirin is actually additive to surveillance. And then the important reason to be cautious about the use of aspirin is the risks of aspirin. Aspirin is associated with GI bleeding and with peptic ulcer disease, and it increases that risk 2 to 6-fold, mostly dependent upon age and other medications. And there's also an increased risk of intracranial hemorrhage. In general, though, the cardiovascular benefits and the decrease in hemorrhagic stroke outweigh this risk of intracranial hemorrhage. Nonetheless, the risks are real, and it's a balance between the benefit and risk when making a decision about aspirin. In my personal opinion, I think that there are certain groups in which aspirin chemoprevention should be discussed, considered, and potentially used, and that is individuals who are at high risk for colorectal cancer, that are at high risk for cardiovascular disease, where aspirin is also beneficial, and at low risk for GI bleeding. That means having no peptic ulcer disease or previous GI bleeds, no aspirin intolerance, no H. pylori infection that increases peptic ulcer disease, and those that are at low risk for intracranial hemorrhage. The major risk factor there is uncontrolled hypertension. So I think that in this subset of patients, it's very reasonable to recommend aspirin as an adjunct to high-quality colorectal cancer screening. But let's move on to screening. I've shown you this type of slide a couple different times showing the decrease in incidence and mortality of colorectal cancer in the United States over time. These curves show what happened during the same period of time in the overall use of colorectal cancer screening. We had no systematic screening programs in the United States in the 70s and 80s. We began to use opportunistic screening, mostly with fecal occult blood testing in the 80s. And then over time, lower endoscopy, mostly colonoscopy, has become the most commonly used colon cancer screening program in the United States. So about 80% of all screening in the United States is now done using colonoscopy, fecal occult blood testing accounting for most of the rest of this, and flexible sigmoidoscopy is minor role. So concomitant with this decrease in incidence and mortality has been an increase in overall screening. The best estimates that are about at least half of this decrease in incidence and mortality is due to screening. Other factors are important. Improvement in treatment is important. Perhaps some lifestyle improvements are important, particularly decreasing rates of smoking. But nonetheless, screening is probably the single most the dominant reason for this decrease in incidence and mortality, particularly in these years since the 1990s when screening has become so common. If this continues, if this increase in screening continues, and the goal, current national goal is 80% screening by 2018, one could predict that we would continue to see a decrease in incidence and mortality. And this is a dramatic effect. This is one of the biggest effects of a medical intervention on an important cause of cancer. So there's really good news. This is something to celebrate, I think. So let's talk a little bit more about screening. Screening is based on this adenoma carcinoma sequence. Different tests have different capacity to identify portions of this sequence. Early detection tests, like looking for blood in the stool, identify lesions that bleed. And cancers bleed, sometimes large adenomas bleed, but these earlier lesions don't bleed. So looking for stool in the blood is primarily provides the ability to detect cancers and some adenomas, but it's primarily an early detection test. Whereas endoscopy and removal of these polyps can identify, not only identify the earlier lesions, but remove them before they can actually progress to cancer. I think the field is moving from early detection to prevention with increased emphasis of trying to use tests that can identify these lesions before they become cancer, and not only decrease cancer mortality, but decrease the need for surgery to treat the early cancers. So let's talk about some of these tests. There are two major guidelines organizations in the United States that people pay attention to: the U.S. Preventive Services Task Force and the Multi-Society GI Task Force. This is sort of a nonpartisan group that's not run by gastroenterologists. There are a lot of gastroenterologists here, so keep that in mind as you look at these recommendations. High sensitivity fecal occult blood testing annually is recommended by both. Flexible sigmoidoscopy, either with or without an interval FOBT, is recommended by both. And colonoscopy every 10 years if it's negative is recommended by both. So these are the screening tests that are recommended by both of these organizations and the ones we'll talk about first. There are some important new tests that I'll talk about in a minute. Fecal occult blood testing, standard fecal occult blood testing was this guaiac-based test, or Hemoccult 2, was done like this. You were given 3 cards, each had 2 windows. You took a popsicle stick and took a piece, 2 different areas of the stool, smeared it on the slide, and then sent that in, and it was tested for with a dye to look for blood. And it had a relatively poor sensitivity both for cancer and very poor for adenomas, but over time, which has been shown to decrease individuals that have annual fecal occult blood testing. It decreases the incidence of mortality of colon cancer, the mortality by about a third, the incidence by about 15 to 20%. It's largely been replaced by higher sensitivity stool tests, and they're both Hemoccult-based tests, these GLAG-based tests, so-called Hemoccult Sensa, which increases the sensitivity for detecting cancer in adenomas, but mostly by these fecal immunochemical tests. And here are a couple of examples of fecal immunochemical tests that are now available. The difference between these two kinds of tests, these GLAG-based tests detect heme, whereas these detect human globin. And so these immunologic tests only detecting human bleeding, and therefore you don't need to change the diet. You don't have to avoid meat to try to decrease the positivity rate due to animal blood. So these have some advantages over these three stool tests and have largely replaced the Hemoccult Sensa and Hemoccult 2 in the standard stool, detecting stool for blood as a screening test for colon cancer. So these are the high sensitivity stool fecal occult blood tests. And then these are the endoscopes, and you're probably very aware of this. This is a flexible sigmoidoscope. It's about 60 centimeters long. This is a colonoscope. It's about 160 centimeters long. The biggest difference between them is their length. They both give a very good view of the colon, and as a result, sigmoidoscopy has the ability to detect about a third to maybe a half of the colon, depending upon how good the endoscopist is, whereas colonoscopy typically can reach the entire colon. So that's the big difference in these two endoscopic approaches. Both of them allow the passage of a snare so that can be put around this polyp and remove it. So it can, these are preventive measures as well as early detection opportunities. These are the best estimates of the relative effectiveness of these colon cancer screening approaches. And I want to make 2 points here. Compare the yellow bars to the red bars. This is the standard Hemoccult versus the fecal immunochemical test, showing a substantially higher effectiveness in reducing the incidence of colon cancer. These are estimates now based on best data, than both the incidence and mortality. So big difference between standard fecal occult blood testing and fecal immunochemical testing. And this has driven this transition from standard Hemoccults to either high sensitivity Heme Sensa or fecal immunochemical tests. But look at the effect on mortality between fecal immunochemical testing done every year, flexible sigmoidoscopy plus fecal immunochemical testing at FlexSig every 5 years with an interval high sensitivity fecal occult blood test versus colonoscopy. These estimates suggest that these are essentially the same on mortality. However, here is the difference in incidence. The endoscopic tests are associated with a larger impact on incidence than the tests that look for blood in the stool. So that's why the recommendations are for all these tests, because they have comparable impact on mortality, and there's a lot of enthusiasm for the endoscopic tests, because they also decrease incidence. I want to speak about newer tests that are available, CT colonography and stool DNA. The U.S. Preventive Services Task Force is said to be reviewing their guidelines, but in the most recent ones, neither of these tests were recommended as on the basis of really insufficient evidence, whereas the reason that the U.S. Preventive Services Task Force thought that they weren't ready at this time. But I think that's being reconsidered, and it's very likely, I think, that one or both of these tests is going to be approved by the U.S. Preventive Services Task Force in their next set of guidelines. The Multi-Society Task Force reviewed essentially the same data, but with a different sort of point of view, and concluded that both of those tests should be included as options for colorectal cancer screening. So what do we know about a little bit about those tests? Here's a third test. The colon capsule has not been approved by anyone for routine screening, but has been approved by the FDA in the United States for people who can't undergo a colonoscopy, people who might be at high risk or on anticoagulants and or for some reason shouldn't undergo a colonoscopy. This is a capsule that you can swallow, and it takes pictures, several pictures every second as you go down through the colon, and it can identify polyps and cancer for the colon. It does pretty well. CT colonography can identify lesions in the colon as well as standard colonoscopy. Cancers and larger adenomas, the ability to detect those lesions are about the same for CT colonography as they are for colonoscopy. All of these tests, colonoscopy, CT colonography, and colon capsule, require prep, and the prep is about the same, really, between all of them. The problem with these, if you identify something, you then have to go, you can't remove it at that time. Colonoscopy has that advantage. The stool DNA test, or the stool DNA fit combination test, is a non-invasive test that doesn't require a prep like these other tests and has that specific advantage. I wanted to show you some data from a recently published trial by Tom Imperiali and colleagues in the New England Journal last year, comparing standard FIT test to this stool DNA test, this multi-targeted stool DNA, which is really a combination of DNA markers and a FIT. Looking at the sensitivity of this test, both for cancer and advanced adenoma, you can see a substantial improvement compared to FIT in the sensitivity for detecting cancer and advanced adenoma. Highly significant differences at the expense of a loss of some sensitivity. That means an increase in the false positive rate. So this is, as we move toward trying to have higher rates of identification of cancer and higher rates, particularly of identification of advanced adenomas, this falls somewhat in the middle. It detects not even half of the advanced adenomas in a single test, but certainly more than we have with the other non-invasive tests. So this is important data that's been recently published. And again, I want to tell you that I serve on the scientific advisory board for the company that makes this test, just so that you know. So what do we know about colorectal cancer screening? And coming back to this family history, screening recommendations vary depending upon risk. In average risk individuals, which are defined as people with no personal or family history of colonic neoplasia, that is adenomas or colon cancer, and no inflammatory bowel disease, the recommendations are to start colon cancer screening at age 50 and to stop somewhere between age 75 and 85, depending upon the status of the patient, how healthy they are. The options for screening in this group include high sensitivity fecal occult blood testing or endoscopic approaches. In increased risk group and higher risk groups, like such as first-degree relatives of patients with colon cancer, the recommendations in general are to start earlier, at age 40 or earlier, depending upon the number of cancers in the family and the age of the cancers in the family. In this group, colonoscopy is the preferred screening strategy. In the hereditary syndromes, the approach is to start much earlier, at age 12 or 25, or depending upon how early the cancers occur, and to use colonoscopy at a very frequent interval, usually annually. In this increased risk group, people that have one or two first-degree relatives with colon cancer, the recommendations vary. If you have a single first-degree relative with colon cancer over the age of 60, the specific recommendations now are generally to start at age 40, and one could use any of the standard approaches. It could be endoscopic approaches, could be stool-based approaches. But in individuals that have a first-degree relative under the age of 60 or more than a first-degree relative, the recommendations are to start screening using colonoscopy at age 40 and to repeat that every 5 years, even if nothing is found. And for families that have really cancer stay under the age of 50, the recommendation is to start 10 years younger than the earliest cancer in the family. So family history is used as a modulation, used to stratify screening. And this is an important issue for those of you who might be on this call who have had colon cancer. It's important that you know you're at increased risk for developing new lesions and need to have screening yourself, but also your relatives are at increased risk. And it's important that you help inform them about that risk and that they're provided with reliable screening recommendations. So how are we doing with respect to this? In general, you can see an increase in colonoscopy screening rates in these populations. Shown in red here, the rates between 2005 and 2010 in individuals that have no family history of colon cancer and anyone. This is the age-eligible population, those over age 50 and don't have a family history of colon cancer. Those rates are increasing. The rates in those with a family history have been higher, as they should be, both in 2005 and 2010, modestly higher in those that have a family history compared to those that don't. But in this age group below age 50, say in the 40 to 50-year-old group, these rates are really low. So colonoscopy screening rates, it's recommended that these individuals have colonoscopy starting at age 40, and those rates are really low. So we have a real effort to make to try to make it clear that the recommendations differ based upon family history and do something to increase screening. Lastly, I'd like to talk about staging of established colon cancer and what we can do if we fail to prevent colon cancer. Colorectal cancers are staged using a standard staging system based upon the depth of penetration of the tumor into the colonic wall, the presence of lymph node metastases, extension of the tumor to local lymph nodes, and spread to other organs. So stage 1 cancers are cancers that extend through the muscularis mucosa into the muscle of the colon wall. Stage 2 cancers are those that extend through the true muscle of the colon wall, and neither stage 1 or stage 2 have nodal involvement. Stage 3 tumors are those where lymph nodes have become affected, tumor cells have spread from the primary tumor to the local lymph nodes. And stage 4 cancers are cancers that can be identified to have spread to other organs. The reason staging is important is because staging is very predictive of survival of cancer. And what's shown over here, again, are stage 1 through 4 colorectal cancers and 5-year survival, the estimates of the range of 5-year survival from different studies. So early stage colon cancer, stage 1 colon cancers, the cure rates for those cancers are range between 80 and 95%. Stage 2 cancers, it falls somewhat to 70 to 75, but a big decrease once nodal involvement occurs to 30 to 65%. And stage 4 cancers have a 5-year survival of around 5% or less, depending upon the extent of disease. So staging of colon cancer is done because it's very predictive of survival, and it predicts, and treatment options are dependent upon the stage of the disease. This is just an overview of colorectal cancer treatment in these early stages, such as the precursor lesions or even some early cancers that haven't penetrated deeply out of the polyp itself. Polyp removal may be enough to treat the cancer. An early stage cancer surgery is the hallmark, or is the mainstay of treatment. Surgery by itself is the only single agent that's curative for colorectal cancer, so enormously important in the treatment of early stage colorectal cancer. In some stage 2 and stage 3 cancers, where the risk of recurrence is higher, adjuvant chemotherapy is a very important adjuvant, has increased overall survival and increased cure rates by 10 to 15% in the best of cases. So adjuvant chemotherapy. And then in radiation as well, particularly rectal cancer, radiation is part of the adjuvant treatment. In stage 4 cancers, in metastatic colon cancers, then chemotherapy, standard chemotherapy plays an important role, and has certainly extended survival. But there are also new agents, anti-EGF receptor antibody therapies and anti-angiogenic therapy that have just been available for the last 5 to 7 years or so. This is the general approach from early stage to later stage cancers and the options for treatment. And this summarizes sort of what's happened in treatment over the years. 5-FU has been available since, I think, the 70s. So 5-fluorouracil is the drug that was used for colon cancer since the 70s. Before that, in the early use of 5-FU, the average survival of patients with colon cancer was around 6 months. But recently, in the mid to late 90s and in the early 2000s, a number of new agents have been shown to be effective in colorectal cancer. And you can see them here, irinotecan. This is oral 5-FU, oxaliplatin. These agents have really improved the effectiveness of systemic chemotherapy in advanced disease, and are now being used in the adjuvant setting, and are more effective than 5-FU alone. Most recently, biologic agents such as antibodies to EGF receptor, antibodies to VEGF and other kinases have become available, and again led to a modest improvement above cytotoxic therapy in overall survival. So that currently the overall survival of individuals identified with metastatic colon cancer is over 30 months. So substantial improvement in survival even if colon cancer occurs and even if it can't be cured surgically. So this is what I tried to cover, what colon cancer is. It's common, it's lethal, it's preventable, and importantly, we've learned in the last 10 years or so that it's molecularly diverse. And everything else may change depending upon the molecular pathway that the cancers are derived from. Everyone's at risk for colon cancer. Age is a dominant risk factor. Family history is an important risk factor. And then there are some groups that are genetically predisposed that can be identified where screening approaches are much more intense. It can be prevented by screening. It's more effective than any of the lifestyle changes that I mentioned, but those lifestyle changes are probably good for your heart, and they're prudent, and they're good for your colon as well. Aspirin chemoprevention, I think, is an important tool in highly selected patients, those that are at low risk of complications. And finally, surgery, adjuvant therapy, and palliative chemotherapy are very important components of folks who develop colorectal cancer, and there have been substantial improvements in all of those approaches over the last couple of decades. And I think we're moving toward molecularly tailored therapy, not only on the basis of mutations that occur in predisposition, but also mutations that occur within the tumors themselves. With that, I'll stop, and thank you for sticking in there. And I think you've had an opportunity to ask questions, and maybe we'll get a chance to answer some of them. Thanks very much.
Great. Thank you so much, Dr. Ahnen. This was wonderful. We've had a lot of really great questions come in, so I was just going to go ahead and ask a few now. So essentially, we have some questions, and I'll kind of group them together, but starting with EGFR inhibitors, could you explain a little bit why EGFR inhibitors are basically effective for patients who are KRAS wild type and not others?
This is a great question, and it really gets to the point of molecular tailoring. So let's start with EGF. EGF is a growth factor that binds to a receptor on the surface of the cell. That binding results in the subsequent activation of a number of different proteins, including activation of a protein called KRAS and activation of a protein called BRAF. There are also known mutations in KRAS and BRAF that activate that system themselves. So if the KRAS is mutated or BRAF is mutated, that same system that EGF activates is activated essentially downstream from the receptor itself, downstream from the binding of EGF to its receptor. So antibodies, and we know that that signaling pathway is an important one in the progression of colorectal cancer. We know from big studies that a small proportion of individuals with colon cancer actually have benefit from inhibition of that pathway with antibodies to the EGF receptor. And some smart people, understanding the biology, said, well, there's only a small portion of folks who benefit, and we know that there are these mutations that can activate the system downstream of the receptor itself. So let's ask the question of whether individuals with those mutations also benefit from inhibition of the EGF receptor signaling pathway upstream at the receptor level. And it was shown quite clearly in several studies that EGF receptor antibodies work in individuals that don't have those mutations, that have wild-type KRAS and BRAF, and don't work in individuals that have mutations in KRAS and BRAF. And the rationale for them not working is that that system is already activated downstream, and therefore inhibition higher in the pathway would not have any additional effect. And so now that's been terrifically beneficial clinically because antibodies to the EGF receptor are expensive, and they don't work in most patients. Now we've identified a group where the likelihood of response is higher, that is, those that have a mutation in RAS or RAF. And so now use of those antibodies is restricted to individuals that have those mutations. Really a major step forward in our understanding of response to therapy on the basis of the mutations that occur in the cancers themselves. Really molecularly tailoring chemotherapy. Hello, are you still
Thank
there?
you so much. And I think
Yeah, sure.
related, hi, yeah, I'm still here. Can you hear me?
Yep.
Perfect. So related to talking about MSI high and microsatellite stable patients, why do patients who are microsatellite stable have poorer prognosis than those who are unstable?
Yeah, so this is really very sophisticated questions here. The microsatellite stability and instability, we should start there. So microsatellite unstable colon cancers were originally identified in patients with Lynch syndrome. As I mentioned, Lynch syndrome is due to a mutation in one of several genes that are necessary for microsatellite, for DNA mismatch repair. So essentially what happens, one time out of a million, when the normal DNA replicates as cells divide, the wrong base pair is put in. And the DNA mismatch repair system repairs all but one of those million mutations. A very high fidelity repair system. If you have a mutation, one of the genes that's necessary for function of that repair system, those mutations, those mismatch repair mutations don't get fixed, and therefore the rate of mutation increases, so-called genomic instability. One of the hallmarks of a loss of DNA mismatch repair is what's called microsatellite instability. So microsatellite unstable colon cancers can occur as a result of loss of DNA mismatch repair. And it occurs in Lynch syndrome, but it also occurs in about half of the cancers that are derived through that third pathway, the epigenetic or serrated pathway, by a different mechanism, not by mutation in one of the genes responsible for DNA mismatch repair, but by hypermethylation of one of the genes is responsible. But nonetheless, those cancers that are microsatellite unstable, regardless of whether they come from Lynch or from this serrated epigenetic pathway, do have a better prognosis, and they do have a differential response to therapy. And that's what I was getting at when saying that both risk factors and treatment are in the future going to be dictated more and more by these pathways. Now, to the question, why do individuals with microsatellite unstable cancers have a better prognosis? The thinking is that what happens is when you have these these mutations that result in microsatellite instability, they create a new what's called a neoepitope, a short sequence of nucleotides that result in amino acids that are new, that are novel, until eventually a stop codon is generated and transcription stops. So no further protein is made. These new proteins that have never been seen by the body are immunogenic, and the more of them you have, the larger the immune response to these neoantigens. And so in Lynch syndrome cancers and microsatellite unstable cancers that occur through the epigenetic pathway, you can see an increased number of lymphocytes in the tumor and frequently see a lymphocyte reaction around the tumor, showing an increased immune response. And the thinking is that that's increased activated immune response that results in the improved survival of individuals with microsatellite unstable cancers, stage for stage, compared to individuals with microsatellite stable cancers.
So related to the different clinical pathways or other pathways of colorectal cancer, so we have testing for Lynch syndrome. How are these other pathways defined, or how do you find out how your cancer was caused?
You're talking about individuals with colon cancer, if you have colon cancer?
Yes, so we have testing for Lynch syndrome. What are the other options to understand these pathways?
Right. Okay, so it's a little bit different. For Lynch syndrome, we routinely test all colon cancers for microsatellite instability, and then in those that are microsatellite unstable, we look for the subset of those that have a germline mutation in one of the DNA repair systems and have Lynch syndrome, and that's a very, very high-risk group. In the broader group of colon cancers, it's really variable at what laboratories do. Some laboratories, including our own at the University of Colorado, does a panel of mutational analyses, which would include RAS and RAF, which would help in decision-making about whether ultimately an EGF receptor antibody would be beneficial, but also includes a few other tumor types, particularly, or a few other genes and mutations in a few other genes, particularly ones that are relevant to some of the new drugs that are being developed to treat colon cancer. New drugs that are being developed because we know of specific mutations that occur in cancers, and then we reason that those mutations would affect this pathway, and we might be able to affect that pathway using drugs. And some of these mutations activate a pathway, and so if you had an inhibitor of that pathway, maybe that would be particularly effective as a tailored approach to these other cancers. So somatic tumor analysis also occurs, and it's variable. Some practices don't do any somatic testing routinely, and others do more. At the University of Colorado, we do a panel of, I think, 10 or 12 specific mutations to try to help both use the medications that we have, the chemotherapy drug approaches that we have now better, as well as to serve as the basis for the potential of selecting agents that might be specifically tailored to an individual's mutational profile.
So thinking about family history, could you define what a first-degree relative is, and then also talk about what resources are out there for family members to talk to their relatives? So if someone's had colorectal cancer, if there are resources for them to talk to their family members about screening.
Yeah, so a first-degree relative is a parent, sibling, or child. So they have 50% of your genes, and so you share 50% of the genes with your siblings, with your parents, and with your children. Second-degree relatives are grandparents, aunts and uncles, and grandchildren. And you share 25% of your DNA. The closer the relative is to you, the more likely it is that genetic features might be related. So we know that individuals that have a first-degree relative with colon cancer are at higher risk than the general population. And we also know that individuals with second-degree relatives are at modestly increased risk, but not as high as if you have a single first-degree relative, or if they're at a younger age, a first-degree relative, or more than a single first-degree relative. So closeness of relativity is part of it. The issue of what to do, I think the most direct thing to do is if you have colon cancer, then you should talk to your relatives and tell them that they're at increased risk. You should talk to their doctor about colon cancer screening earlier than we usually recommend talking about colon cancer screening. We recommend starting screening at age 50, so we recommend talking to your doctor, your healthcare provider before that, and then start screening at age 50. But if you have a family history, so the relatives of those of you on this call that have had colon cancers should know that the recommendations for them are to start earlier at age 40, and sometimes even earlier than that, depending upon the age of the cancers. And so they should talk to their provider about colon cancer screening in their late 30s, because starting at age 40 may be the appropriate approach. Not everyone that has a family history of colon cancer is at an increased enough risk to warrant starting at age 40. But everyone that has a family history of colon cancer should talk to their provider about what's appropriate screening for them based upon their family history. And that discussion should start before age 40 rather than wait until age 50.
Wonderful. Well, with that, I'm going to go ahead and wrap up the question and answer session. I'll leave it to you, Dr. Ahnen, to close with any final thoughts that you have or any resources that you think the audience should be aware of.
Well, I just want to thank you for putting this together. It's always fun to talk about colon cancer, and that's my favorite organ. Yeah, the colon is. And so I think the important points to know about colon cancer is that it's very common, and it's very preventable, and it's very treatable. And so that early detection as well as prevention are important, and that there's really good news and really a cause to celebrate as a result of the efforts that have already been made that are decreasing incidence and mortality from this disease, particularly in the United States, but much of the Western world. And continuing those efforts, I think we're going to continue to see, hopefully continue to see a decline in this disease. Really the most dramatic decrease of any of the major cancers in the United States, other than what occurred previously with lung cancer. So I'll stop there.
Awesome. Thank you so much. We really appreciate it. And yeah, please find us on the website, fightcolorectalcancer.org. If you have any other questions, feel free to get in touch with us. But thank you, Dr. Ahnen, so much. We really appreciate it.
You bet. Thank you.